Our next speaker is Dr. Stephen Russell. He is an assistant professor of medicine at the Harvard Medical School and an attending physician at Massachusetts General Hospital. He completed his MD, PhD training at the University of Texas Southwestern Medical School and a residency in internal medicine and a fellowship in endocrinology at the Massachusetts General Hospital. Dr. Russell is a principal clinical investigator of a collaboration between the Massachusetts General Hospital and Boston University to develop a wearable bionic pancreas system for automated glycemic management in people with diabetes mellitus. The title of his topic is Automating Diabetes Care with a Bionic Pancreas. Please welcome Dr. Russell.
Thank you very much. I'm honored to be here with such eminent speakers. So I hope you'll cut me some slack. I'm not a pediatrician, but we are working on a pediatric disease. And our particular interest is type 1 diabetes, of course. These are my disclosures. The challenge that kids and their parents face when they're challenged with type 1 diabetes is really immense. So these are kids that are asked to do something that we don't ask of essentially any other patient in medicine. We ask them to do their own testing and make their own decisions about how much of a drug to give. And if they make the wrong decision about the dose of the drug, they can become seriously ill or even die from a severe hypoglycemic event. On the other hand, if they aren't aggressive enough at managing their insulin, they can wind up with long-term complications of diabetes. So we ask them to walk this tightrope, and we ask them to do it with some guidance from us, but really they're much more on their own than almost any other disease I can think of. So this lack of adequate tools that we have to help people with diabetes means that most of them don't meet guidelines that are set by the American Diabetes Association for glycemic regulation. It turns out that only about 30% of adults have an A1C of 7% or less. And the situation is even worse for children. 14% of children have an A1C that meets these guidelines, even though the guidelines are more lax for children with type 1 diabetes than they are for adults. So what we're trying to do to change this is to change the game. We're trying to really make a fundamental paradigm shift in the way we manage type 1 diabetes. And we're trying to do that by changing the model of care. So currently, patients with diabetes have to check their blood glucose multiple times a day. They have to count their carbohydrates. And a lucky few of them are able to take advantage of continuous glucose monitoring, where they get blood glucose testing essentially every 5 minutes throughout the day. Only about 10% of people currently use continuous glucose monitoring. But then they have to integrate all this information along with a bunch of unmeasured factors and make a decision about insulin dosing. And then they have to deliver that dose, and then the response is very unpredictable. Every patient, every parent will tell you that they can have the exact same situation, the same blood glucose, the same amount of carbs, and they give the same amount of insulin and something completely different happens. And that's because there's so many unmeasured factors. In children that are running and active, the amount of activity that they've just participated in can have a profound effect on the way that insulin is going to affect them. Post-menarche, the time of the menstrual cycle can change insulin sensitivity. So all these unmeasured factors make it tremendously challenging. So what we're trying to do is we're trying to take away a lot of this work that the patient has to do or the parent has to do, and we're going to focus on the ability of this continuous glucose monitor to measure the blood glucose every 5 minutes, and we're going to try and take full advantage of that information. And instead of asking the patient to make decisions, we're going to substitute a computer algorithm to make those decisions. And that computer algorithm is going to learn about that patient's individual insulin needs. The dosing decisions will be made by the algorithm. The dose delivery will be made by the algorithm. And in addition to using insulin, we're going to use glucagon as well. So we're going to take advantage of both the insulin to lower blood glucose and glucagon to raise blood glucose, just as the normally functioning pancreas does. Of course, people with type 1 diabetes still have their alpha cells in their pancreas, but in the absence of the beta cells, the alpha cells no longer secrete glucagon in response to hypoglycemia. So we're missing a critical element in the hypoglycemic response. And then, of course, we still have an unpredictable response to therapy to a degree, but we can make a new decision 288 times a day, every 5 minutes. And so we don't have to invest as much in each decision, and we can compensate for decisions that seemed like a good one at the time, but then later activity by the patient turned out it wasn't the right decision, but we can make an adjustment to compensate for that. So the reason we're using glucagon is we believe that even perfect insulin dosing wouldn't be enough. Imagine a scenario where you've given just the right amount of insulin to balance the amount of carbohydrates that you're taking in, and the blood glucose is right at 100 milligrams per deciliter and stable. But then the child decides to exercise, or the adult has to run for a bus. Now you have insulin-independent glucose uptake into the muscle that couldn't be anticipated by the bionic pancreas. And you can stop giving insulin at that point, but the problem is that insulin, even rapid-acting insulin, is absorbed very slowly. It takes more than an hour to reach a peak in blood after a dose is given. So stopping the insulin delivery at that point isn't going to have much effect on the plasma insulin levels for quite some time. And exercise can make the blood glucose drop very rapidly. It's typical for it to drop at 2 milligrams per deciliter per minute. So within 15 minutes, you're going to be hypoglycemic. Stopping insulin delivery is not going to prevent that. However, if we give a small dose of glucagon subcutaneously, glucagon is absorbed much more rapidly, has a time to peak in blood of 15 to 20 minutes, and we can bend that curve. We can make the blood glucose rebound until stopping the delivery of insulin can have its effect. So we can buy time for that withdrawal of insulin to work. So the system we're using uses an algorithm that was developed by my colleagues at Boston University, Ed Damiano and Faraz El-Khatib. Ed got involved because his son developed type 1 diabetes when he was 13 months of age. He was an applied mathematician and decided to turn his talents from fluid mechanics to managing type 1 diabetes. The algorithm is unique in that it uses only the patient's weight for initial scaling of dosing, uses no information about the past insulin requirements, partly because the past insulin regimen may not be very good, but partly because we know that insulin requirements change over time, and we want a system that's robustly adaptive. For instance, to deal with development, insulin needs go up dramatically in pre-adolescence, in the transition to adolescence, and then go down again in the transition to adulthood. We want a system that won't require adjustments from the doctor to deal with those changes. And it adapts to the individual's insulin needs over approximately 18 hours. And the other thing that we're trying to do is we're trying to reduce the burden of diabetes. So this system doesn't require any carbohydrate counting at all. You don't have to tell it anything about what you're eating, and it will automatically regulate blood glucose. But if you choose to decide to tell it about a meal, all you do is announce it in a qualitative fashion. This is a typical breakfast for me. This is a typical lunch for me. This is more than typical, less than typical. And then the system learns what the individual means by that and gives a fraction of the insulin that's going to be necessary as a way to get some insulin on board and try and deal with this delayed absorption that we have to deal with, but then the rest of the insulin will be automatically managed by the bionic pancreas. So this is an example of what one of these experiments looks like. This is one of our very first experiments. The glucose is shown with that black trace on the graph. The green and blue range is 70 to 180 milligrams per deciliter, or the target range. And the rectangles down in the pink area are meals that are given. And you can see that when a meal is given, the blood starts to. The blue strikes downward represent doses of insulin, so the system automatically starts dosing insulin. And in this case, no meal announcement was given. It turns the blood glucose around and drops it down towards the normal range. But you can see it looks like maybe the system gave a little bit too much insulin in this case. And if that trend from that first meal continued, we'd be in the hypoglycemic range. But a small amount of glucagon is enough to bend that curve, and a tiny additional amount of glucagon levels out the blood glucose. And then the interplay between little adjustments of every 5-minute dosing of insulin and glucagon keeps the blood glucose in the target range overnight. And so this is typical of the way that the bionic pancreas works. The amount of glucagon we're talking about is very small. That quote-unquote big dose of glucagon, the largest one there, is 15 micrograms of glucagon. And one of those red rescue kits that we hand out to parents to use if their child is unconscious and can't eat and has a low blood sugar, those are 1 milligram. So this is 1.5% of one of those doses. So as long as the insulin is regulated carefully, it doesn't take very much glucagon to bend the curve if you have just a little bit too much insulin on board. So we've been doing experiments for some time after we did initial experiments in the hospital with a wearable version of the Bionic Pancreas. And this uses a continuous glucose monitor, in this case the Dexcom continuous glucose monitor, back to back in an enclosure with an iPhone, which runs an app which implements the Bionic Pancreas algorithm. And then that app makes decisions about insulin and glucagon dosing, and it remotely controls 2 insulin pumps, tandem insulin pumps, and then they deliver insulin and/or glucagon via subcutaneous infusion sets. And the user interface is very, very simple. When announcing meals, if you choose to do it, and we know that many people won't, many adolescents in particular probably won't, all they say is that they're having breakfast, lunch, or dinner, and then is it a typical amount, a less than typical amount, or a more than typical amount? And then the system will ask if they're sure, and then will deliver 75% of the insulin that it predicts that they will need for that meal based on their history. So we've done a number of studies. We've done some studies in adults that were published last year in the New England Journal of Medicine. And we've also done a number of studies in children in the diabetes camp, and I'm going to tell you about those. The study we did in adolescents is published in that New England Journal article, and the one in pre-adolescent children is not yet published. The little girl in the middle was 6 years old. She's the youngest child that we've had on the Bionic Pancreas. You can see her size because the iPhone is as wide as her chest. So, of course, this system is not a system we'll eventually commercialize. It'll be much smaller, but it allowed us to get out into the outpatient setting where there were real challenges to the function of the Bionic Pancreas. And then on your right is me in my work uniform. I don't usually dress in a suit. That's what I looked like when I was at the camp with 2 of the campers. So on top, this is an example of our comparator. In this study, we had 5 days in the Bionic Pancreas versus 5 days of camp care, plus some additional monitoring. And these were in random order in kids who were at camp for 2 weeks. They participated in all the camp activities. They were integrated, scattered among the cabins with all the other kids. And as you know, the camp provides a lot of support for kids with diabetes, and they typically get a much better mean blood glucose than they do at home because they have a counselor who has diabetes, they have a nurse assigned to each cabin, a doctor adjusts their insulin every day. But you can see that they visit the normal range, again, the target range, the green and blue area, only from hypoglycemia to extreme hyperglycemia and back again. And that's because the camp is an extremely challenging environment. They're eating large meals, they're very, very active. And so even with all the support that the camp provides, this particular child had a mean glucose of 197, plus or minus 101, pretty wide standard deviation, and 4.7% of the time was less than 60 milligrams per deciliter. So that same child on the Bionic Pancreas has a much calmer glucose profile. Now you can see that the Bionic Pancreas has to have time to adapt. So that first meal, it doesn't handle very well. They still had a hyperglycemic episode, but then the Bionic Pancreas gets more aggressive because it sees this adolescent needs more insulin, and it manages to tighten down the blood glucose range. And you can see that the mean on the Bionic Pancreas was 149 milligrams per deciliter with a much smaller standard deviation, and 0.8% of the time was less than 60 milligrams per deciliter. So this is a graph that shows the summary of all the kids. This was 16 boys and 16 girls from the ages of 12 to 20 at the camp. On the left of the diagram, each point represents a mean glucose on camp care, and the size of the circle, the diameter of the circle, is proportional to the amount of time less than 60 milligrams per deciliter. And on the right is the same kids connected through a blue line on the Bionic Pancreas. And you can see that we've dramatically narrowed the range of mean blood glucoses, and we've reduced the amount of hypoglycemia. The mean glucose went from 158 to 142, so 158 is already very, very good. The camp is doing a good job, but that represents a very wide range of mean blood glucose, some with very high mean blood glucoses, some with very low, and quite a bit of hypoglycemia. The Bionic Pancreas tightens that up very, very dramatically. But interestingly, it uses the same amount of insulin on average as the kids under normal care. Completed a similar study in children 6 through 11 years of age, and you can see we get a very similar result. We lower the overall mean blood glucose, we tighten up the range very dramatically, and again, that's a function of the adaptive nature of the Bionic Pancreas. If the mean glucose is too high on one day, the system is more aggressive the next day, and vice versa. And so we've lowered the mean blood glucose again, and at the same time reduced the amount of hypoglycemia while using about the same amount of insulin. And perhaps more important than all those metrics, this is a note sent home from Elise, which I showed you earlier. Dear Mom and Dad, Matthias and Lucas, I miss you very much and am having so much fun, and the Bionic Pancreas is doing good. So I was happy to see that. The parents sent that to me. So we just completed a trial recently, which is our first home use trial, where we take the Bionic Pancreas, we train people on its use, and we send them home. And in this trial, we only ask that they stay within a geographic area so that if we had any technical problems, we could reach them easily enough. So we did this at 4 sites. This was the Boston and the California site. And this is a summary of all those results. This is 11 days of Bionic Pancreas in the home environment, no restrictions. People could drive, do their jobs, exercise, eat whatever they wished. And the Bionic Pancreas compared to the control period, 11 days in random order. And you can see, again, we lower the mean blood glucose. We reduce the amount of hypoglycemia dramatically. And you can see the amount of hypoglycemia has been reduced in each of these trials as we make advances in optimizing our algorithm. The adults in this trial only had 1.9% of the time hypoglycemia under usual care and a mean blood glucose of 162. So these are people who are doing spectacularly well, but we still improved it with the Bionic Pancreas. And perhaps most importantly, that dashed red line there, I showed you with the pediatric study as well, that dashed red line is the mean blood glucose that would be predicted to meet an A1C goal. So in this case, 7.5% for these children. And you can see that every single kid had a mean blood glucose that was in that range. And in the adult trial, all but a few of them had a mean blood glucose that would be predicted to give them an A1C less than 7%. But at the same time, we've reduced hypoglycemia from 1.9% to 0.6% of the time without using more insulin. And one more thing before I close. This is an example of the mean blood glucose over 11 days in usual care for one of our subjects. And this is a subject who's doing very well, has a mean blood glucose in the 150s, high 150s, but you see that their average varies a lot from day to day. Their insulin dosage probably doesn't vary quite so much, but the control they're able to achieve with that varies quite a bit from day to day. And you can see that at night, their mean blood glucoses tend to be higher, and that's related to fear of hypoglycemia at night when they are unable to do anything about it. And it's also true for parents. I mean, parents of kids with type 1 will tell you they never sleep again, not the same way they used to. So this is on the usual care for this patient, really doing quite well. This is that same patient on the Bionic Pancreas, and this is very, very typical. So the Bionic Pancreas, almost every day is like every other day in terms of mean blood glucose. Very little change from day to day to day, almost no variability. It hones in on the general scaling of dosing, but then it adjusts insulin dosing from day to day based on what they eat, how much activity they have. And the other thing to notice is that we actually get a lower mean blood glucose overnight, the opposite of what we typically see with patients with type 1, because the system doesn't sleep. And the nighttime is actually easier. There's no meals, there's no exercise. It's a perfect time for maintaining a very good mean, and that, of course, contributes to the overall good mean that we see. So we've now incorporated this algorithm into a new device that's intended ultimately for commercialization. It's a fully integrated device with 2 pump reservoirs. It's going to use insulin pen cartridges, one for insulin, one for glucagon. It has connectors that are designed so it's impossible to cross them up. You can't accidentally put the insulin in the glucagon reservoir. And this system has a receiver for the CGM, and all of the algorithm smarts are integrated into this device. And we are now preparing for a pivotal trial that will start in the beginning of 2017. We're going to be doing some bridging studies between now and then. And we've agreed with the FDA a design that will be sufficient to get all the data we need to have approval of the Bionic Pancreas, to assess its safety and efficacy. Also, a new stable form of glucagon that is stable for many, many days at room temperature. So it's going to be sufficient for the approval for chronic use of that glucagon. And they are going to let us submit our data for a PMA, a pre-market application for approval, at the end of a 6-month randomized period of this study, which is in fact a year-long study. So we could actually have this device approved for sale as early as the end of 2018. So, It is our hope that we will really change the paradigm of diabetes care, and so that the current way of doing things, as shown on this slide, will seem very, very old-fashioned in just a few years. And of course, we'd love to be put out of business by a cure for diabetes. I think everybody who works in the diabetes space would like that. But in the meantime, until that happens, we think we can reduce the burden of diabetes, we can reduce the fear associated with diabetes, we can reduce complications associated with diabetes. And that is our goal. And we have a website, bionicpancreas.org, if you're interested in more information. Thank you very much.